Hello, everyone. I hope you're well. So today's conversation is with Nicholas Fabiano. Nicholas is a psychiatrist in residency. He's already written several papers, which I'll put here, and you should see them, which are the sort of foundation of our conversation. And they predominantly center around the role of exercise on mental health, principally depression. And then Nicholas speaks about sort of his perspective on psychiatry, the kind of perhaps at times artificial or unnecessary bifurcation between mind and matter, the physical and the mental, and actually at times how sort of things like exercise can kind of bridge those. And then Nicholas also speaks about the his thoughts on the interdisciplinary nature of science, which yeah, I really appreciated those thoughts, and I thought they're quite interesting. So yeah, I hope you enjoy the conversation and have a nice day.
No, for sure. And I can tell you a little about myself. You probably know a little bit from the Twitter side of things, but yeah. So I'm a third year psychiatry resident, and right now I'm at the University of Ottawa. So my particular interest lies kind of between the overlap between physical and mental health. You could probably tell from some of my papers, but I'm also all over the place with that. My main interest is kind of the use of lifestyle interventions for mental disorders. More recently, I focused on exercise and depression, but my grand scheme is to kind of expand to more mental disorders for exercise, but also using things like diet, sleep, and more recently, I've been writing about like things like creatine and different
Yes.
nutritional supplements, which are more traditionally used for like going to the gym and stuff like that, but more so applying it in a different lens. So that's kind of where my interests lie. They're all over the place, but
Mhm.
yeah, great to be here.
And yeah, great to talk to you. And just going off that, what you said there, I wonder in a way for those perhaps who aren't that maybe I'm sure you've probably encountered misconceptions as to what psychiatry is. And I
Mhm.
imagine one of those is that it's solely, oh, I don't know, maybe quite narrow in the sense of it's merely uh giving out pills. Whereas actually I
Mhm.
wonder for you if you could or your journey and the work you're doing attests to the fact that it's a lot broader than that.
Mhm. Yeah, so I think in psychiatry we often look for the treatment of many disorders to be kind of this two splits where you can either do medications or therapy, which, largely when you're looking at first line treatments for many disorders, that's kind of the route you take. However, as you mentioned, in psychiatry, I think even going a little bit further back, the issue we come to is the dichotomy we make between mental and physical health. So we draw this arbitrary line between these two entities, when in reality they both influence one another quite significantly. So that's where I think there's a lot of utility for interventions that can target both of them. So sometimes, as I mentioned before, you know, medications and stuff like that, it's great. It can help with symptoms of different disorders. It can help treat. It can help stuff get into remission. However, you're not looking at the full picture sometimes. And another thing, using depression as an example, not all depressions are the same. There's different causative factors. There's different things that are associated with it. So I think it's important to, yes, it's great to have treatment options like antidepressants or medications and therapy, but at the same time, we want to look at things that are more holistic, like exercise, like diet, like sleep. And these, I view them to be like the fundamentals of someone's health, not just mental health, but your health. And inevitably, if it's a fundamental, it's going to interact with all the different variables in your life. And it can result in someone feeling depressed if maybe something is off, or it can make someone, have different symptoms of different mental disorders if something's just not quite right. And not to say that these things are all causative for these, like not saying that just because you don't exercise a lot, you're going to be depressed. However, it's something that could be a factor in some of this big causal web of what we call mental health, which has really sparked my interest. And then the other lens of it too is going back to the medication piece that you mentioned. A lot of the meds that we use in psychiatry specifically, they have a lot of side effects that can adversely impact someone's mental or sorry, physical health. And one that is quite bothersome for people is just simply things like weight gain, which happens with antidepressants, particularly happens with antipsychotic medications. And things like exercise can help combat some of that as well too. So if you're starting someone on one of these medications, not only do you have the antidepressant benefits of the exercise regimen, but also you're looking at the physical health of the individual too. So that's kind of where my interest kind of came from that perspective. And then I always think it's important to share my own bias as well too, not from a financial perspective, but I've always been someone that played sports my whole life, currently, go to the gym pretty regularly. I personally really do enjoy like exercise and things like that. So I acknowledge my own bias in that realm too. Although there's no financial conflicts,
Hmm.
um, it is my own bias that I have there, but it's also a motivating factor that really makes me want to learn more about this area.
Yeah, sure. And I suppose, yeah, just demonstrates your enthusiasm for it.
Mhm.
And so then I suppose talking about the work you have done so far, I mean, I know off the top of my head there's at least I can't remember how many of them were meta-analysis, maybe more than one, but there was at least one you've done exploring
Mhm.
sort of exercise and depression, and then I know also I can't remember if it was a formal study or if it was more of like an opinion piece where you then spoke about like counteracting some of the maybe there was some news that was put out basically
Mhm.
comparing the impact or the efficacy of exercise versus what are they called, antidepressants. So what
Mhm.
has the research you've done so far
Mhm.
shown with regards to exercise and I think predominantly it's been depression, right?
Yeah, so the paper that you're alluding to is a commentary or editorial that I recently wrote. Um, Kind of as you mentioned, correcting the notion that was widely disseminated before. So again, acknowledging my own bias, exercise is great. It has all these benefits. However, about a year and a half ago, a study came out in the British Journal of Sports Medicine. And it was a really big umbrella review looking at exercise interventions for, I believe it was mental health in general, like depression, anxiety, stuff of that. But they compared it to medications and therapy. Um, Now, that meta analysis was great, but it was misconstrued in the media to show that exercise was 1.5 times as effective compared to antidepressants or therapy. Now, while again, I want the message to be disseminated that exercise is great, it's important that we're very clear and honest about kind of what is to be expected and what the actual numbers show. And in meta-analyses after that, so network meta-analysis, what I mean by that is when you're comparing indirect associations, you can kind of get more studies and compare different things. It's shown that exercise is at best comparable to antidepressants or therapy. So it's still really good. And as I mentioned before, with a lot of those side effect perspective profile, it's a really good option. But it's important to communicate that it's not going to be this miracle cure.
Sure.
So in that piece, that's kind of how we reframe things. We first went through the evidence kind of from a more balanced lens, hoping to kind of correct that notion that exercise was 1.5 times better, but instead reframing it that it was equivalent to some of the first line treatment options. And in that piece, we also discussed, exercise, at least in Canada where I'm at, is a first line treatment option for depression. And more so in the mild to moderate depression. So it wouldn't be fair to suggest it to someone that has a severe depression. But that's something that lots of people aren't aware about. So whether you're a primary care doctor, whether you're even a psychiatrist, a lot of people aren't aware of that. So I thought that was an important message to get across.
Hmm.
And then to touch on the last point that you mentioned too, with regards to kind of the multi-system benefits of exercise, we specifically in that paper, we discussed a trial that compared running compared to antidepressants and looked at depression scores and anxiety. And for that, what the paper found was, again, similar benefits in depression and anxiety scores. However, there was improvements in weight, waist circumference, blood pressure, heart rate variability. So these are all important factors of one's physical health, which go into that whole big picture that I described before of not looking at the individuals in isolated, mood or sleep or stuff like that, but instead a big picture. Because you can imagine how that would indirectly or directly influence someone's mood or overall health state.
Sure.
So that was the point we made from that end. And then the other point, though, to discuss within that paper too, is although there are less side effects that one experiences with exercise, so you can still get things like a sore knee or something if you're running. Um, there's a higher dropout rate, at least in randomized control trials, for people who do exercise interventions, and this probably shows that it is harder for someone to go through with an exercise intervention than it is to take a pill every day, even if it's causing side effects. But I think that puts an onus of responsibility on the physician and allied health to really make sure that these people are prepared and ready to exercise and feel well supported to kind of be able to do these things to really up that adherence. And then the other thing too is again, it's a randomized control trial, and those are ideal settings or quote unquote ideal settings in the RCT. So in the real world, I would imagine the adherence rate is even lower. But that gap, although it can be disheartening, I think it should be motivating for those in the field to say, what can we change to make it that adherence rate higher? Because the simplest thing is in exercise, the more you do it, the better it's going to be for your physical health, for your mental health. So that's the biggest thing, at least in my view, that we need to focus on as physicians is if we're going to help patients do this, how do we make them do that like effectively?
Yes. And so I wonder how much you can comment on so whilst you've just elaborated or referred to the kind of multi-level, how I suppose exercise as an intervention is maybe like remediating, or we can explain what it's doing at multiple levels. With regards to the sort of the more, how do you say, the physiological side of it, and then maybe like the neuronal elements, where is the field in terms of, is it quite, does it feel, does the literature suggest that there's a good grasp on what's going on, or is it still quite putative, like that these are what we think's happening? I know you've mentioned, for example, brain derived neurotrophic factor and things like that. Is that the kind of principle? Yeah, does that make sense?
Yeah. So I think to split it up in the dichotomy that I don't like, but to split it up
Yes.
for sake of discussion, from a physical sense, the benefits of exercise, the literature is vast. There's thousands and thousands and thousands of papers, and whether it's heart health, kidney health, any organ you pick, you're going to find a surplus of papers to describe the benefits of exercise. And again, not an overarching theme where all exercise of all intensities is going to be beneficial for everyone, but from a general sense of saying that exercise is generally beneficial for one's physical health. But there can be nuances depending on people that have different medical conditions and stuff of that sort. But from the mental health perspective, and to narrow it down more to even depression, it's a little bit more nuanced because whenever I'm asked this question, I like to take a step back further and ask the first question is, do we even know what causes depression from a neurobiological perspective? And the answer right now is no. Like we have a lot of different theories and I know there's a lot of discussion, especially recently, with regards to serotonin, norepinephrine, dopamine, neuroplasticity, and all of these different things that we think either could be a result of depression, could be caused by or causing depression. And, that's beyond even this discussion here. But that's just to say that if we don't know necessarily what's causing depression, it's hard to say a direct biological correlate of how exercise may alleviate it. So how I reframe it is, I think it's best to look at it from a biopsychosocial lens. So there's still the biological part that we can talk about. So biologically, as you mentioned, we know that exercise increases BDNF, or brain-derived neurotrophic factor, which is essentially like miracle grow for the brain. So that's one of the things that we see. We also see changes in brain sizes. So something I've even written about recently is like changes in the hippocampus size. We know that exercise can reduce inflammation, which again is a very broad thing. Lots of everything that we see now reduces inflammation and stuff of that sort.
Yeah.
But I think it's just all these little pieces come together that potentially contribute to the antidepressant effects. But I can't tell you with certainty that any of these markers specifically are the reason for the antidepressant effects of exercise. But then when you look at it from the other lenses, so we spoke about bio in part, socially, exercise is something that oftentimes you do with other people. And times that I'm thinking of now is, during, the pandemic or something, when maybe you were home a lot and exercising was the only time you got out to see another human being. Or particularly like older individuals that, if they're widowed, they don't have anyone with them anymore, going to that exercise class or whatever they're doing may be the only point of social contact that they have. So I think that's a very important factor to consider because that social factor is so important, even if you remove the exercise part, especially in a time where I would argue that we're more lonely as people. Like we're online a lot, but we're not seeing people in person as much as maybe previous times. So I think that's another important factor to consider. And that all factors into the psychological aspect of where we see the antidepressant effects. But beyond that, again, the web is quite large. Like you have benefits to cognition, you have benefits to anxiety, and all of these factors impact one another. And I think it's important to look at it from that lens because even not exercise, but if you look at anything and you try to reduce it to a very simplistic view, it's not it's not going to be the answer. That's my opinion, at least. If
Sure.
you say one neurotransmitter or one thing is causing this very broad and not heterogeneous, homogeneous, sorry, condition, you're gonna you're not gonna have a correct answer to that. It's not going to be as simple as that. And that's just my opinion. Some people might disagree with that, but I think that's where it's important to consider the complexities, because that also goes into the prescription of exercise. You're not going to just do it for everyone, because that's not fair. But I think it's important to look at each person as an individual person, and that their depression or their experience is unique. So you can't just apply medications, therapy, or exercise, or diet, or any of these factors just
Sure.
across the board. It's about talking to the person in front of you and seeing how that can help.
And that, yeah, and so then as a sort of as an intervention, exercise is a lot more, the best word that comes to mind is holistic. And so,
Mhm.
and then it makes me wonder when if one is interested in perhaps trying to compare it to other interventions, albeit actually as you talk, I'm starting more and more to wonder actually, hmm, what utility is there in the comparison rather than just trying to find the kind of against something like an antidepressant versus just not treatment as usual, but like just exercise versus nothing, like just a kind of basically what I'm saying is because an SSRI is not as holistic. It's not necessarily implicating or drawing on the sort of psychosocial. People don't necessarily go to bars where they dispense SSRIs and have a chat over it. It's very
Mhm.
much just that, and so it makes it difficult, I'm guessing, to tease apart the sort of efficacy, at least if you're or trying to understand the different. Does that make sense?
Yeah, and I think another thing too with it, when you compare these interventions, you have to think of the control arm for even therapy and stuff like that. If you're, again, to give the example of exercise versus antidepressants, it's very easy to give a control for an antidepressant. You give a sugar pill or something,
Mm.
and it's pretty well masked. But with exercise and similar exercise, similar to like the psychedelic field, it's quite hard to blind someone to exercising, right? Like you can't, if you quite literally blindfold them, they're going to know they're exercising, right? So
Yeah, yeah,
you have expectancy effects from that, like you, and sometimes in these RCTs too, they're called patient preference RCTs, where they allow people to choose the arm they go into, whether that be exercise or whatever the comparator is. And you can imagine the people that are choosing to go into exercise already have their own bias that, oh, this might work, or their baseline demographics might be different, such that maybe their depression is less severe, or maybe there's a different factor, a confounding variable that's contributing to why the exercise is more beneficial. So that's a big thing to consider when you're comparing different treatments, is the blinding. And that is a weakness of the exercise field, although it doesn't completely take away from the legitimacy of the trials. It's something to consider when you're making one-to-one comparisons. You have to ask, what are they comparing to?
right, right.
Just because, as you mentioned, they're not the same intervention. It's much different things that come with it, and much different placebos that they use in these different trials.
Sure. And what do you find, okay, so at the moment then, most interesting? Is it sort of, are you interested in perhaps exploring or further understanding? Because I suppose exercise itself is a quite a broad construct. It's you've got anaerobic, aerobic, low intensity,
Mhm.
high intensity, and is there a lot to say with regards to that in terms of generally is one on average better than another, or is it quite sort of ideographic, the variance? Is it one thing for one person is going to have more of a benefit than perhaps another person?
Yeah, no, it's a great question. And I think there's a lot of studies that look into this. So breaking down the exercise type, and the large types that we break them down to is like aerobic, resistance. So aerobic is something like running, resistance is something like weight training, whereas mind body would be the other one, which is like yoga and stuff of that sort. So those are the large kind of classes, at least in the academic literature, that exercise is broken upon. And of course, there's things that fall in between there. And I guess maybe now is a good time to even break it down further in terms of like exercise prescriptions, and how we go about that, just to kind of give everyone an idea of kind of the different types and how you can kind of prescribe exercise. With medications, oftentimes, and not oftentimes, you always prescribe the medication itself, the dose that the patient is taking, and the route that they take it, and how often they take it. With exercise, oftentimes you just, like, the doctor will just say, go for a run, go exercise. It's not very actionable sort of stuff. So with this, as I mentioned, there's different types of exercise that you can have prescribed and stuff of that sort. But we often refer to the FIT principle for exercise. So it's FITT. So when I spoke about the type, that was one of the T's at the end. But to just start from the beginning again. So F is, when you're looking at exercise, is the frequency, is how often is someone exercising per week. That could be 1 time, 0 time, 5 times, as much as you want. Intensity is then broken up into the low, moderate, or vigorous intensity. And just to give an explanation for that as well, too, just for context of like what that means, you can have a bunch of different parameters that you measure to see where someone's at in their exercise intensity. But the simplest thing is just the talk test. So you can, low intensity, you can talk, sing, do whatever. It's not super a lot of effort that you're exerting. Moderate, you can still talk, probably a little bit more difficult. It's harder now, and you probably can't sing to someone beside you. And then vigorous is like you're just going so hard you cannot talk, do anything. The other T we spoke about was type, and then the last is timing. So that is how long those sessions are. So is it a quick 10-minute, like you were saying, like high intensity session, or is it a longer session that's an hour or two sort of thing? And that was just a long-winded way just to explain that that's how the literature looks at exercise in broad scopes. And again, when we look at kind of comparisons, there's lots of randomized control trials that compare aerobic versus resistance versus all of these different things. And to be honest, a lot of them show conflicting results. There's not one clear winner in terms of this one is better than that, or this one is better than this, because all of these randomized control trials are in different populations, even if it's for depression specifically. It can be an older individual where, as an example, usually we see exercise intensity is proportional to the antidepressant response. However, in someone who's older, we actually see better antidepressant response in lower intensity, so lower moderate versus going higher. And that's probably a reflection of their body's ability to kind of actually do that exercise. And it's too much for them to go to that extent. So that's just one example. And that's why you kind of get into tricky spots when you try to compare what is the best for the person in front of you. Because again, going back to it, it's a very complex picture of what will best suit that person in front of you, their age, their interests, their previous experiences. And I think that's where we get into trouble, where sometimes we overfit this RCT data onto people when it doesn't really fit. So what I find instead is, in general terms, the greater intensity, the better. The frequency we look for is about 3 to 5 times per week. The session's about 45 minutes to 60 minutes. And then the type, honestly, it's pretty similar across the board. Most of the literature is in aerobic exercise, just because it's the easiest to put someone on a bike or run. But that doesn't mean that the rest are necessarily worse. So my guidance for that would be to just talk to the person in front of you. Like, what do they want to do? Because the biggest factor that's not included in the FIT principle is adherence. And that's going to be the most important thing. You can prescribe someone the best exercise regimen, or the quote unquote best exercise regimen, and if they don't do it, it's not going to work. So the most important thing is that you talk to the person in front of you. Number one, do they even want to do this? Because maybe now is not the time to talk about exercise. You can become a very obnoxious doctor if you're going to everyone and saying, you're depressed, you should exercise. And even sometimes when I'm sharing this on X or Twitter, I get that response sometimes, but my view is not that I think everyone should do this. It's that it's an option for people. It's important that you're on the same page as the patient in front of you, that, is this something that you want to do? If no, that's totally okay too. And it should be a discussion that you're willing to revisit in the future if the time comes. But again, working with the patient, say they rock climb, they really like that. That doesn't fit into your FIT principle for this session, but it's still great. They're getting out there, they're socializing, they're exerting themselves. That's perfect. I think that's awesome. And sometimes you can dissuade patients if they're not meeting these 3 to 5 times or the 60-minute sessions. Like, honestly, in the practical sense, not who cares, but it's better that they're doing something. So that's kind of what the lens that I take with that. And the same thing goes with diet and stuff. Like you can have the perfect diet of all these different things that you put together for health, for mental health. But if it isn't sustainable, money wise, time wise for preparation, just tastes bad, it's probably not going to work. So it's the same thing
Mm.
with exercise, and that's the principle I take across. I think sometimes we get, especially academics, we get too lost in the numbers, and we say this effect size is 0.2 better than this. Well, we have to use this, but it doesn't matter. It doesn't matter because we're not in a randomized control trial. We're in real life.
Yeah, yeah, interesting. And a point you made a few points back around this sort of the response you sometimes get, which maybe at times is, I'm guessing, is under, it comes under that sentiment of maybe it being invalidating. And this is the point not everyone's the same, because someone might be, I don't know, chronically depressed or just very depressed, and their doctor's just saying, well, you just need to go for a run. And actually,
Mhm.
and even if we don't take that person, let's say somebody who's moderately depressed or any type of whatever how you describe their depression, that I'm wondering anyway, if that exercise is not necessarily, you're not, or the literature is not always suggesting that it's going to, how do we say, remediate the, if we hypothetically say that there is a causal mechanism or something that's causing the depression,
Mhm.
that the exercise is not necessarily about remediating that, but it can still have an antidepressive effect, and
Mhm.
that then there might still need to be other support, whether that's psychotherapy, possibly depending on the, assuming that there are different etiologies to depression. Again,
Mhm.
hypothetically, somebody's might be more, the variants might come through, I don't know, again, hypothetically, I'm not saying this is the case, but genetics versus somebody where there's quite clearly, some early life adversity and things like that. So exercise in of itself is not necessarily remediating the difficulty. And this also links on to a point you've made before around whereby self-harm, sorry, exercise can almost become a form of self-harm.
Mhm.
Um, you have said that, right?
Yep. Yep. I wrote a
Yeah,
whole article on that actually too.
yeah,
Yeah.
I read it. Yeah, 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 I read it. And I suppose because, and that's kind of strange, because then at the same time you're saying, but exercise can be sort of have an antidepressant effect, and yet at the same time it can be a form of self-harm. And I think that just speaks, doesn't it, perhaps to the what's lying beneath it. What are the mechanisms which are mediating the depression, and yeah, basically.
Yeah, no, and it's a great point you bring up with that because just like anything in life, too much of it or too high of a dose or something can be toxic. Like you can take water, you can maybe for lack of a better overdose on water. Maybe it's not overdose is the right word, but you can have too much of it to cause harm. But just to speak to the exercise as a self-harm piece, I can kind of give a little bit of background in terms of where that came from. That was a commentary that I had just kind of thought about, honestly. I was just kind of thinking about different things, and I had published two meta-analyses on the topic, not that specific topic, but a related topic in the year prior. So we did one looking at exercise and suicidal ideation, suicide attempts, and suicide deaths. One in randomized control trials and one in observational studies. And across both, we found that exercise decreased suicide attempts, but it didn't decrease deaths by suicide or, surprisingly, even suicidal ideation, which means, the thoughts of suicide
Yeah, that
itself.
was it. Yeah, I read that. Yeah.
Yeah, yeah. So from there, what I had initially thought with my lens of, exercise is so good, and I still think that, is that because we didn't see an increase in deaths, and we didn't see a change in ideation, but we just saw a change in attempts, we know that most suicide attempts are characterized by high impulsivity and low lethality. So that means someone spur of the moment gets into something that really dysregulates them, and they do something that they're probably going to regret later. And luckily, it's not of a severity where often that they end up taking their lives. So from that, we thought that perhaps exercise is reducing one's emotional impulsivity to different situations, and there is literature to support that. So that's kind of what we ran with that idea. But then, like a year, I guess later, I was just kind of thinking about the topic, and having spoken to different athletes and different things like that, it kind of changed my view a little bit in terms of what could be going on. And again, I want to frame this conversation, and it's an opinion piece. I don't have evidence to back up this theory, but it's more of kind of a thought of what was going on. So again, to revisit it, we've spoken about exercise with its antidepressant effects, how it can be beneficial, how it may even reduce suicide attempts. However, sometimes you have to look at the reasoning for someone exercising. So sometimes not even exercise, but people have different maladaptive coping things. And it's very controversial to call exercise a maladaptive coping skill because, in the traditional sense, it's good, right? It's good for your health, it's good for all these things. However, I think it's important to look at the intent behind it because sometimes, and this surprisingly really resonated with a lot of people when I shared this online, being like, wow, I feel very heard about this, was that people, whether they're going to the gym, whether they're running for a very long time, they're going, some people, with the intent of wanting to feel that pain or wanting to almost hurt themselves because it's almost akin to traditional self-harm that we see. We usually think of cutting, burning, stuff like that as self-harm. We don't usually think of exercise outside of eating disorders. In eating disorders, we accept that, but we don't really think of exercise to be something that's harmful or a self-harm method in other areas. So my view on this was that perhaps there is a subpopulation of people that are not being recognized by their family, by their doctors, because they say, I'm depressed, I'm having a hard time, whether they had, they lost their job, they went through a breakup. And they said, but, I'm still going to the gym 7 times a week. So immediately the doctor, everyone is reassured. They're like, oh, doing great, everything's okay. And, maybe that is the case for a lot of people, but maybe not for everyone. Maybe that person who's going to the gym is going there with the intent of harming themselves. And outwardly, it looks like they're doing better. They're gaining muscle, they're more fit, and it looks so it's this hidden population that maybe we're not really catching. And as I mentioned before, although exercise does also have antidepressant effects, it doesn't work for everyone. So you can have this chronically hurt population that's just in this cycle of exercise, not for the quote unquote good benefits, but more so from the self harm perspective. And there is an argument that perhaps that's still adaptive, maybe not. Maybe this is a form of sublimation sort of thing. However, I think it at least is something that we should be aware of as a family member, as a doctor, to talk to your patient about and just ask that extra question, be like, saying, I see it's great you're going to the gym 7 days a week, but like, what does it do for you? Is it helping you? Because I think we automatically assume it is. And, for the most part, you're probably right. But I think there is a population. And from what I've seen, at least from the response to that article when I shared that, it resonated with a lot of people and a lot of people that were athletes or people that are in this realm where exercise is their identity. It was quite surprising to see that it was almost used as a form of self-harm by them as well, too. So again, overall, more a theory. We still need to work on actually having correlates and actual data to support it. But I think that will be something that will hopefully come out soon. But just an interesting thought that I had had.
Yeah, it is, and it makes me think because what I think when I hear that is, yeah, that makes sense. Particularly, let's say somebody's doing it and actually, it's seen as some sort of like avoidance or not even avoidance. Yeah, like it means that it's a self-harm. And then actually maybe it's like exploring with that person, well, what's the function of this? And is there a more, is there a healthy way, a more adaptive way, which is going to help, sort of remediate the distress which you're trying to downregulate through exercise, maybe through therapy or something. However, there's also the question of, even if it is a form of, it's controversial, but if it's that instead of somebody burning themselves, it's a kind of tricky one, isn't it? But it's definitely something that it's really the fact that you've had such a response is I suppose really encouraging, and actually particularly if it's not something people have recognized much before in the literature and stuff. And that kind of makes me think about, just because of the dynamics of sort of self-harm and stuff. And you mentioned earlier on around exercise and different diagnoses. Is that what you said? Were you saying that you're starting to think about in the future exploring, because we've been speaking really around depression. Is that something you're thinking about, you'd like, or is it just a case of you think you'd like to in the future maybe explore it with different diagnoses?
Yeah, no, I think eventually my goal would be to kind of gain more expertise across diagnoses, because I do think there is utility across different diagnoses. The only thing that's holding me back right now is I have my exam next year for residency, so I need to
Oh, really?
focus on studying that. But after that, I'll have lots of time. But as an example, one thing, if we're thinking of the two extremes of like mental disorders, and this is not fair to say, but to say depression is maybe one of the less, severe mental illness, mental disorders compared to something like schizophrenia. That would be a
Hmm.
good contrast to make in terms of the spectrum of mental disorders. And I do acknowledge that severe depression can have psychosis. It can be very debilitating for someone, but just for the
Hmm.
sake of discussion, to say these two different disorders, say we're comparing a mild depression compared to schizophrenia. We spoke at lengths in terms of the depression standpoint and how it can benefit there. But even something like schizophrenia, there's benefits to exercise. Now, I'm not saying that we treat schizophrenia just with exercise. We don't use the medications to help with their symptoms. But if you break down the symptoms of schizophrenia, it can be very helpful for even that as well too. And there are nuances to prescribing exercise to someone with schizophrenia compared to someone with depression. So I think there's a lot of work there that I hope to get into. But just for discussion's sake, with schizophrenia, for simplicity, we break it down into a few symptoms. So we know people have positive symptoms of schizophrenia. So that's when they're hearing things or they're seeing things. And I also acknowledge not all these symptoms are present at once. There are the negative symptoms of schizophrenia. So when someone lacks the motivation, there's a lack of speech. It's just the lack thereof of something that would be there in someone that doesn't have schizophrenia. And then you also have the part of the negative symptoms, sometimes people group it in as the cognitive symptoms of schizophrenia. So we know over the course of the illness, and particularly when someone is experiencing psychosis, their cognition is significantly impaired. And there's argument as well as that medications might contribute to this too. So when we break down those symptoms, we have three. Again, there's more than that in schizophrenia, but just for simplicity's sake of discussion, we know that exercise, as we've spoken about before, in depression can help with cognition, and there's evidence to show that as well in schizophrenia. So that alone is a benefit to the cognitive standpoint and the impacts that schizophrenia may have on one. Then, when we look at the positive and negative symptoms, there's actually trials to show that as well. Exercise results in reduction in the positive and negative symptoms of schizophrenia. Now, is it to the point of remission where you can stop your antipsychotic medication? No, but perhaps that allows a discussion around better control of symptoms, perhaps less remission rates, and perhaps even lower doses of medication. Who knows? Like, there's not a lot of
Mm.
research in the area. And then to the point that I discussed at the beginning when we started speaking is yes, antidepressants are associated with metabolic side effects, so weight gain and stuff like that. But if we want to talk about medications that have significant metabolic side effects, it's the antipsychotic medications. I've seen people on medications like olanzapine gain 60 pounds in a year. You see these people develop diabetes. You see them have issues with their hearts, their kidneys,
Right.
often as a result of chronic use of these medications that they need to take. Otherwise, they're going to have remission or not remission. They're going to have their symptoms come back. Um, and oftentimes we don't do a whole lot to mitigate those side effects. Because I could tell you if I was that person in their shoes and you're telling me you're going to start me on a medication that's going to start or cause me to gain significant amount of weight, potentially have diabetes and all these other physical ailments, I'm not going to take my medication probably. And that's what we see a lot, right? You see a lot of people that have schizophrenia that decide, I'm not going to take my medication anymore. And
Hmm.
whether that's a lack of insight into the illness, whether that is due to side effects, there's a lot of literature around that. But if you can at least minimize the side effects from a human to human sort of thing in terms of prescribing a medication that you know is going to have side effects, there's a lot of utility to help. Again, as I mentioned, from the three-pronged approach from the symptoms, the positive, negative, and then the cognitive symptoms, but then also from the lens of the side effects from the medications that we currently have. And I do note the newer antipsychotic medications that are coming out, and I actually did a paper on this too recently, but this isn't the point of this conversation. But xanomeline trospium is a new antipsychotic that came out too that was just FDA approved, and it seems to have less of these weight gain and metabolic adverse effects, although early phases. But it loops into my interest too because I think it looks at someone as more of a whole person from that perspective rather than just prescribing a medication that has such adverse effects, even though it's needed in that instance. And I do acknowledge not all antipsychotics result in these effects. However, it is something that can happen. which is something we need to be aware of. And that's where I do see the utility of exercise across the spectrum of mental disorders, beyond just depression.
Nice. Well, I think we've exercised quite well there, and so it
Sure.
makes me wonder, because you've done some work on diet as well.
Hmm. Hmm.
So what have you found in terms of the relationship between diet and, I think again it's predominantly been depression, right?
Yeah, yeah. Yeah, so with diet, I don't have as much expertise in this, but I did write a few pieces on this. Diet is where exercise was probably a few years ago. Like exercise is a much larger field with more body of literature to support it. The diet field is starting to grow more and more, particularly more within the depression side of things. So the first big trial in the dietary realm was the Smiles trial. And essentially, I don't have all the specifics with regards to this, but they randomized people to a dietary intervention versus not. And they saw significant antidepressant effects for those that received the dietary intervention. And that's what really sparked the community to say, hey, maybe there's something here. And along the same lens of the exercise standpoint, diet really gets down to the fundamentals of, your health and your mental health. And it has benefits to both the physical and mental side of things, which is why I see so much benefit in it. And right now, as I mentioned, there's not a whole lot of research, and there's no studies that are, as I spoke about before, comparing diet to medications and therapy, which is always creates an interesting point for conversation. However, the most studied diet right now is the Mediterranean diet, and there was a very small meta-analysis. I forget how many studies were included in it, which lumped together all of the randomized control trials. And it found an antidepressant effect, not the same extent as exercise. However, again, these trials are very in early days. There's not a whole lot of them. So I think it's a very promising area. However, I think there's a lot to kind of still develop in terms of doing that. And it goes along the same realms of exercise in terms of like, how do you really prescribe that? Because there's a lot of nuances to diet. And I don't have a fancy acronym, unfortunately, for diet, but maybe that's something that becomes a thing in the future. Um, but I think it's important as the physician too, if you're going to be prescribing diet to someone, you need to be able to have that discussion with them so that it's actionable. You can track it with them. And it needs to be something that's sustainable too, right? Because if we're being realistic, compared one to one, a healthier diet is oftentimes more expensive than this ultra processed food diet that you can easily get a hold of. And that's nuanced because if you're always ordering food online and getting it shipped to your door, that will probably be more expensive and more unhealthy. However, there's the time commitment that goes into preparing meals and all of these different things. But I think it's a very interesting field that kind of lumps in with the exercise. And
Yeah.
something that we didn't speak about before is all of these interventions sometimes, as you termed before, the holistic view. So you would lump like diet, exercise, sleep in that. They don't have to be used in isolation. You can use diet, exercise, sleep together. It's probably it is better actually. And you can lump the other things together too. You can still try antidepressants. You can still do therapy. But we know there's synergistic effects with these things. I haven't seen a trial putting all of them together. But I would imagine that there would be benefits to one's physical and mental health in a synergistic way when you're combining all of them. Because logically, you can think if someone is sleeping well, they're getting their 8 hours, they're eating healthy, they're exercising, they have that energy, and they're going to therapy. Perhaps there's a trauma aspect to it. They're able to discuss this and speak to someone about stuff. And maybe even medication helps a little bit in terms of activation and stuff of that sort. You can imagine with all of those things. I'm not saying that everyone needs to be on everything, but you can imagine that with all these tools we have, there's different ways to combine them in such a way that you can personalize it for the person in front of you, but also maximize the antidepressant effects. And then not to get lost in the number of the antidepressant effects, but to remember that it benefits a lot of things. So whether you help anxiety, that's going to indirectly help depression. Whether you help cognition, that's going to impact depression. And it's not just a one way arrow, it goes both ways. So I think that's an important thing too. When we look at all of these holistic interventions like diet, exercise, sleep, and combine it with our more quote unquote traditional ones, we don't have to use them in isolation and they benefit one another. And then again, looking at mental illness as almost like a web. There's so many factors that contribute to everything. And if you tweak one of those things that maybe we could say is off, for lack of a better word, that little can fix this thing, fix this, fix that. And it's all these interactions happen from one change. And that one change can be exercise. That one change can be sleeping 1 more hour per night. That one change could be eating breakfast. Like maybe you're just skipping breakfast. That's your dietary intervention. But yeah, that was a long-winded way of describing the diet side of things.
Yeah.
Um,
Well, yeah. Well, it's interesting. What it makes me think though, as well, is when you're describing it, I wonder as well at times if maybe it happens with, I can't speak to psychiatrists because in terms of I've never really like spent much time. Well, I have, but not in as much as you would have had. But also patients in the sense of underestimating the efficacy of some of these interventions because on the surface they just sound so simple. Not to say
mhm,
they're actually then, whilst they might be in terms of implementing them. Again, I say simple in the knowledge that actually for some people they're really not, and they're actually quite
mhm,
challenging. And there's different factors of whether that's economic, if it's food, or finding a space to actually exercise if somebody lives in a certain environment.
mhm,
But actually, underneath it, though, if one wanted to, you could explore it and you could model it in a lot of detail at different levels. The sort of
mhm,
psychological level, the biological level, and so yeah, it just makes me think of actually, do we? Yeah, maybe we've underestimated and can continue to underestimate the efficacy of these interventions, i.e., diet, sleep, and I imagine, well, increasingly this is changing with people like yourself, doing work into it. But I wonder if that has
mhm,
been, and what your thoughts are on why it hasn't been sort of taken up as much as
mhm.
possibly it could have been. Yeah.
Yeah. I think there's a multitude of factors of why. I think one of them, and this extends beyond even psychiatry, is oftentimes a notion is there's something wrong with me and I need a quick fix. And I think what's been put into our minds as just human beings or consumers in our economy is that oftentimes a pill can just fix like everything. And that's something that I oftentimes see even in when I'm working in the emergency department and seeing patients like in consultation, and there's a lot going on. There's a lot in distress, and oftentimes, and I've been even told before, like I just need the pill to fix it, like some sort of
Mm.
pill or something. So we look at that, and that's kind of what we hope for, and then it almost sets us up for defeat because we know that these medications, although they're helpful, they take a while to work. The first one doesn't always help. There are side effects with them too, and that sets people up for defeat. And the other thing too, in terms of what really propels research into interventions as well too, is if you look at things like exercise, diet, and sleep, I think in simplicity's terms, not a lot of people profit from being able to really look into these interventions. Whereas when you're looking at medications and different things, there is
Mm.
direct financial interest in developing a new medication for depression or for schizophrenia.
Mm-hmm.
And what that does is it drives industry to be able to fund studies, to be able to do all these things. And these are necessary to get FDA approval for all of these different things.
Yeah.
And here, the thing is, the reality is, I think some people look at that that's a very bad thing, right? That there's pharma involvement, et cetera, et cetera. It can be if it's not disclosed and you're not transparent. However, the reality of the research field is, as you've seen with, I think in the US right now, with all the NIH budget cuts and everything like that, money is not easy to come by to do the studies that you want to do. So sometimes when you have industry saying, hey, do you want to run this RCT? I can fund it. That allows someone to do their research. But if you don't
Yes.
have the
Yes.
same thing for someone that's doing exercise research or sleep or diet, it becomes a lot harder if you're just relying on applying for grants, which at least in Canada, it's not easy. And I know it's the same across the world to secure these grants for different things.
Mm.
So it becomes a thing where culture wise, to get the funding and to do all these different things, it's set up such that the medication side of things is it's easier to go down that route. The medication or
Mm.
the novel treatments like psychedelics or like TMS, like it's just appealing because you can invest in that. It is interesting stuff, but that's why more money goes into it as well too, because there is profit to be made for other people. Maybe not the scientists directly, but the
Are you
people that are.
including? When you say TMS and psychedelics? Are you saying they are interventions which might be more? There is a sort of an incentive financially. Or are you saying there's not so much with those?
No, I'm saying that there also is with those versus things like exercise or something.
I see. Right, right, right.
Yeah, yeah. So it's similar. I'm looking at it from the lens, and again, no bias from that side of thing, but just looking at it from the lens of that to fund these trials, to do these studies, it takes a lot of money, takes a lot of
Mm,
resources. So it's hard to get that similar amount for exercise. You can imagine if you're doing a randomized control trial with a personalized trainer for 500 people. That's going to be a lot of time, a lot of money, a lot of things.
yeah,
And there's grants and everything for that, but it's not easy to just get. So that's why
yeah.
you see a shift in the amount of literature there exists for medications versus diet versus different things. And I think in current times, we're seeing a little bit of a switch over now, especially with the general public's interest in some of the more metabolic interventions with people like Chris Palmer and stuff that are spearheading that side of things, which is really good to see. And I think we'll continue to see that trend. But I think it's more of the kind of undoing of where things were before. And we're almost learning again backwards from the fundamentals. But I think people are becoming more and more aware, which is important because that will really drive that interest. It'll drive more research. It'll drive more discussion around it. And that will ultimately lead to more solid evidence to support different interventions, which may be more holistic or maybe look at the whole person sort of thing.
Mm. Yeah, sure. And also I wonder as well, what's another sort of gust of wind, so to speak, which is influencing it, is maybe like a broader, maybe it's always been, or it's, I don't know if it's been a gradual thing, or but a paradigm shift maybe within psychiatry. There's less, perhaps, 100 years ago with like Kraepelin and stuff, it was, and that sort of very strict, quite sort of like, I guess you might say, neural reductionist approach, where it was
Mm-hmm.
merely that. And so then things like medication make more sense because it's like, well, that's what we're dealing with. Whereas maybe psychiatry is opening up, has opened up a bit more to be a bit more, is considering other factors, the sort of the
Mm-hmm.
psychosocial, as and integrating it with the biological. So then
Mm-hmm.
things like exercise and diet become more amenable to that, whereas in the past it might have just been a bit less sort of, well, that doesn't make sense
Mm-hmm.
because it's just they've got an aberrant serotonergic system or something, which can only be remediated with SSRIs.
Mm-hmm.
Yeah. And then you meant, I mean, I don't want to put you on the spot and ask you, because I don't know how much research you've done into it, but
Mm-hmm.
psychedelics, I know you were authored on one paper. Is that
Mm-hmm.
something you find interesting then at the moment?
Mm. Yeah, no, I think it's an interesting area. I've authored, I think, a few papers on psychedelics. You're probably referring to the one, was it the schizophrenia
Sorry,
one?
I saw, yeah, maybe I didn't do enough of a search. I
Oh,
can't
that's
remember if
okay.
it was the one where I think it even talked about, am I getting this completely wrong? Like gastrointestinal difficulties and
Okay.
stuff.
Okay, that
Um,
might be, I think I've
it,
done,
yeah,
oh,
sorry,
sorry.
carry on. No, no, you carry on, you carry
Oh
on.
no. But yeah, no, I think psychedelics are an interesting area that we're kind of looking into their effects, particularly, in treatment-resistant populations, in PTSD, in depression. I think it's interesting always to look at new treatments. Um, and I do think there's utility potentially, and it sounds crazy, but to loop in exercise as maybe not while on psychedelics, but as some sort of a adjunct to the treatment, whether
Hmm.
it's before and maybe not immediately after, but a little bit spaced out from a almost neuroplasticity lens. Because
Mm.
to lump in TMS, there's some preliminary studies out of Ottawa that are ongoing right now that I'm helping out with that are looking at using exercise as an adjunct to TMS. And the
Okay.
results, I believe, are not published yet, but it's showing promising results. And again, it's from that neuroplasticity lens. So I think there could be a similar sort of thing with psychedelics. But then the other thing is the harms as well too. So I think the paper you might be alluding to was we did a review on beyond psilocybins. We just looked at it was called Beyond Psilocybin, and we just
Remember,
looked
yeah.
at the safety of these different agents.
Yeah, that
So
was
it
it,
was
I'm
just a big
sure.
review and kind of just summarized different side effects. And to be honest, I can't even speak to all of the nuances in that because it was just a bunch of papers that we put together and
Mm.
said overall things are pretty safe. Essentially, was the
Yeah.
underlying line. However, there's things to consider. But building on the safety piece, one thing that we published recently, I think it was in the last month in JAMA Psychiatry, was an article looking at hallucinogen use, so not just psychedelics, and there's nuances around the term of that as well too, and risk of developing schizophrenia. So
Hmm.
essentially, what that study was set up was it was a cohort. We had a very large cohort of individuals. I want to say I forget several million at least,
Oh,
um,
wow.
and then we took a subset of that population. So it was essentially people who came to emerge or had a hospital interaction for psychedelic use. So it could be any different code that was in the system. So this is a database study that we looked at stuff kind of after the fact. And then we looked at someone's risk of developing schizophrenia after. And there was quite significant elevations in that. And again, when I'm describing this data, it's important to say that this is not causal data. So this does not mean
Sure.
that hallucinogens cause schizophrenia. And there's a lot of
Yeah.
nuances in terms of the coding of what hallucinogen means. This
Hmm.
term is lumped by the provider who saw the patient. So it
Hmm.
can include a lot of different things. So it doesn't just mean things like psilocybin, etc. It can be a whole lot of things. But we did see that increased risk, which is something to at least consider. And our group has also done previous work in a very similar study in JAMA Psychiatry on cannabis and risk of schizophrenia.
Hmm.
Now, it wasn't as high as cannabis use in terms of that transition risk. However, there still was that association, which, although not causal, it at least raises alarms just to say, what is going on here? One important limitation, though, and I don't know the exact number, is that people that use psychedelics or hallucinogens, most of them also use cannabis.
Hmm.
So it's hard to say that someone, based on a database study, coming into the emerge or whatever healthcare contact they had, wasn't also using something like cannabis. That can't be completely ruled out as a confounding factor.
Hmm.
And there are also a multitude of other confounding factors that go on with psychedelic use. So whether it's previous mental health diagnosis, whether it's
Sure.
previous admissions, stuff like that, all of these factor into that association. So it's not to say that necessarily psychedelics cause schizophrenia or a psychotic disorder. However, it's just kind of raising caution because I think one thing when we're speaking about psychedelics and how it's framed to the general public, and I've shared a lot of studies on psychedelics as well too, like on my X or Twitter. Sometimes it's believed to be that the psychedelic is what's resulting in all of the antidepressant effects, but when the media shares it, it's often unpaired from the therapy portion. So most of these trials are psychedelic assisted psychotherapy, not just a dose of psilocybin, but it gets misconstrued sometimes to the public as, psilocybin results in X benefit
Sure.
without the therapy. And I think that's what leads to maybe some people that see that and they say, oh, I have depression that didn't work with antidepressants or something. I'll go get some psilocybin, see what happens.
Yeah.
And not only are they not in a safe environment, like a clinical environment with someone there, but also there isn't that therapy component. So those expected benefits likely won't be there, and there's probably a much higher risk of some of the adverse events that we had mentioned before. Um, but yeah, that's kind of my interest within the psychedelic field. I'm more peripheral in terms of it. It's an interesting field to me. I think
Yeah.
there's some promising interventions and perhaps some synergy with the exercise side of things as well too.
Yeah, that is interesting, and it makes me think of Robert Carhart Harris,
Yep.
and he's, I think, one of the sort of really he's spearheading a lot of the psychedelic research. And I know there's one paper which I read, which is really interesting, and it's you've mentioned plasticity, and he speaks about like canalization and I think he posits. I think he calls it rebus. So, was it
Mhm.
relaxed beliefs under
Psychedelics or
psychedelics? Yeah,
yeah,
is that would be right? How would I don't know?
I
But
guess
raising,
yeah.
yeah. Anyway, but yeah, the relaxing of beliefs, and that makes sense with what you're saying with the psychotherapy point of view, because merely relaxing our beliefs might not be sufficient, but actually we need another agent or a person to help us explore a state space which we hadn't, which
Mhm.
have been locked off from us due to our like highly precise beliefs about the world.
Mhm.
And yeah, and then I suppose in a way, and that makes me think actually related to exercise, because I've been thinking more and more about psychopathology, in terms of that language of like predictive processing, canalization, becoming sort of locked in a state space. And like you
Mhm.
talk about neuroplasticity and this idea of opening up that state space sort of
Mm,
neuronally, like people like Carhart Harris posit, like neuronally. So
mm,
there's like there's greater possibility for postsynaptic gain and stuff. But then
mm,
you spoke about the running and the plasticity, and I was thinking that's like I still do run a lot, but when I at one point I found it really beneficial and it helped me in some, I
mm,
suppose I could say, difficult times. And one of the things
mm,
I noticed was, and this was running outdoors, but
mm,
my attention, I felt like it really, I started to notice more and more how my attention was sort of being grabbed by things in the world which I hadn't perhaps had been sort of shut down a bit from. And
mm,
it just made me think about that being one of the sort of benefits of exercise and running, in that it's sort of your attention is essentially captured by things which perhaps you hitherto didn't see as salient, and that in itself can
mm,
improve like metacognition and stuff, and you're like, well, actually, oh yeah, there is more
mm,
going on and stuff. So just that
mm,
kind of like how exercise, yeah, is sort of like um yeah, you can look at it at multiple levels.
Yeah, and I think with that lens, and this is off topic a little bit, but a way that I like to sometimes look at depression or even mental disorders. I'm not sure if you've heard of the dynamical systems theories of
I'm aware of it, and I think I have a tentative understanding of it.
yeah, yeah.
Yeah.
And honestly, same with me. But I've written about it a little bit just on X and stuff, just because it was interesting to me. But I think it's an interesting way to look at antidepressant effects of a lot of different interventions, like psychedelics is a prime example, or exercise. When you're saying that when you're running, you became aware of these other things. In dynamical systems, if you were to look at it, and I can't draw a graph, but if you have something that's kind of like this, and you have a divot down here, this divot here represents the depressive state. Oftentimes we use the term resilience as a good thing throughout life, like someone's resilient if they get through a hard time. However, in dynamical systems, they reframe the word resilience to sometimes be a bad thing. So this dip here represents resilience. You're resilient because you're stuck in that depressed state. And when you look at interventions from a neuroplasticity lens or et cetera, like exercise, psychedelics, what it helps do is almost flatten that landscape. So rather than it being a divot like this, where you are a ball in that divot,
Yes.
exercise or psychedelics can help flatten it. So maybe it's like this now, and you're still stuck in that depressed state more often than you are on these other sides, but something can push you out. So say, as an example, you have this divot, you graduate from university. That would be something that's happy to you, right? That would be something that's like, wow, I did that. But if you're so far down in this divot, you're gonna like bump up a little bit, but you don't come out. You're
Mm.
just you stay sad. But in this view, if you're exercising against psychedelics, both, maybe not at the same time, um, but that divot now is like this. So you have that bump
Mm.
and you can get out. You can get out. And that divot's still there. So something might push you back in, but you can more freely move in and out of that.
Mhm.
So the goal of it is not to completely flatten it out. There are times, and it's normal to be sad. It's normal to have these emotions. You don't want to just be a flat landscape of a ball that's just rolling everywhere and you feel nothing.
Mm.
But the goal is to make that divot less resilient, if that makes sense.
Right.
And that can be done through exercise and psychedelics. It can be done through antidepressants, therapy. It's just a way to look at mental disorders. And I think it's quite of an interesting way because it's a concept that's applied across different specialties too. Like when I say specialty, not within medicine, even like in the ecological landscape and stuff. That's where this concept came from. And I can't even speak to the nuances there because I don't know enough about it. But I think it's an interesting thing, and that is something that I've tried to do is read outside of my specialty, even if I don't know 100% what it is. I think the biggest medical discoveries are between specialties. And when I say specialties, I use that word, I shouldn't be using that, are between disciplines. So things
Mhm.
that you don't even think are related. And I don't even have an answer for this, but something like physics and psychiatry. They're seemingly, a lot of people would say they're not related. And therefore, you have these researchers that are looking at their antidepressants, exercise, etc. You have these people that are doing their quantum theory, whatever. But no
Yeah.
one looks in between because we're in academia. We become so specialized, and in medicine specifically, there's psychiatrists that only do child psychiatry and a specific this, specific that, so that you're an expert in this one thing, and you're great at your clinical care for this one thing, and that's great, but you get stuck in these different areas that you can't really, if you're the specialist here, you don't talk to this person here, you're never going to have an idea here, and that's where we're at with academia, with medicine and everything. So that's why I think I don't know how I even got to this part, but it's important
Mm.
that we should not only read outside of our discipline, but we should talk to people outside of our discipline. And in medicine, that goes beyond, like, I do projects with people in internal medicines, whether that's cardiology, whether that's nephrology, because I think it's important from that side. But
Mm.
even going a step further, like, it's crazy. Like, work with a physicist, work with different people, different disciplines, and you'd be really amazed at what ideas you come up with, or what
Sure.
links or parallels may exist in your different fields. And I
Yeah.
think that's where we need to kind of look towards too, is stop working in these silos of academia, but to work with each other and also read each other's stuff, even if you can't read it fully. And that's kind of loops back to what I do with my X or Twitter. Some of the things that I'm not an expert in everything. I read a lot of things, and I don't always 100%. I'm not an expert in them, but I read them with interest, and I
Mm.
read it and say, how can this be applied to what my interest is? Even if
Mm.
it's something like physics or something that I haven't taken since undergrad, I still try my best. I look up all the different equations. I learn them, not to a level of a PhD professor or a researcher, but enough for me to say, "Oh, that's interesting." And
Mhm.
perhaps there's errors in my interpretation and stuff like that. But
Mhm.
I think it's important for science to progress, that you know stuff outside of your discipline, and by discipline I mean broadly out of your discipline, so that you can kind of keep learning.
Yeah, I think I agree actually, and I think that makes a lot of sense. And maybe it's just my the curiosity I've always had. But basically, what the only reason I'm bringing myself in is because of the reflections I've had, and it makes me, because the thing you're observing, I'm wondering, well, why has that been? Why do people find themselves in silos? And I know for myself, whilst my sort of say bread and butter, but what I'm is and professionally psychology.
Mm,
Naturally, like I mentioned earlier, I like to drift into philosophy, and I've taken like some courses in maths, again, like
mm,
nothing sophisticated and things like that. Psychiatry, even theology and things like this. But what I sometimes find is, because I spread myself so much at times,
mm,
I can feel really inadequate, and I can think, oh my gosh, I know nothing, because then I'm listening to somebody
mm,
who's actually an expert in that area, and they're so
mm,
proficient, and they're so I don't know. I'm just thinking out loud, um,
mm,
but I agree. I think it's yeah, and I mean that makes me think of the free energy principle, which I think is a great example of where it's sort of borrowed from like statistical physics, and then it's sort of like now sort of being used in like neurobiology and robotics and all AI, all of that. And actually,
mm,
another one is interesting is there's a philosopher who I spoke with on this podcast called he. He's got a. I was just say Peter S. Hughes. He's a philosopher. He's got like a
mm,
sort of a Scandinavian name, so it's hard to
mm.
pronounce. He'll forgive
That's
me.
okay.
Um, but
I'll look it up after.
yeah, yeah. But basically, so he's a philosopher, and he's a very much aware of. In fact, I think recently at Exeter University, he's just, I don't know if you say co-founded the sort of psychedelic research group there. But
Mm,
as a philosopher, one might initially go, well, what kind of, how can there be utility in philosophy with psychedelic therapies? But actually, he's
mm,
really putting forward some, I think, interesting ideas as to how, for some people, maybe at least, really considering the, how would we say, the experiences, whilst we might, or some professionals, maybe psychiatrists or biologists, might focus more on the neurobiology, actually, and
mm,
how that can help people, uh, explore, epistemically forage, so to speak, Whereas he's
mm,
actually saying, what about the spiritual experiences, the metaphysical assumptions that underlie, a person's beliefs, which, these drugs, even if the person may never really have considered metaphysics, they take a
mm,
psychedelic, and suddenly they're having to contend with all these
mm,
experiences which are making them reflect in ways. So yeah, like you say, I
mm.
think it's true. Yeah.
No, I agree. I think it's, and to that point, um, is, as scientists, academics, clinicians, I think the culture, and this is a bigger discussion in terms of publishing and all of that stuff. We've almost entered this rat race of, you. It's publish or perish, and that's a term that's used a lot. But what that doesn't allow for is just time to just think, and that's so important. And some people might think that's silly, like we're paying these people just to sit there and think on their stool and with their hand on their chin. But it's important, like, even some of these ideas like this, the exercise and self-harm, and I know that's not anything that's huge, But that was an idea that just came from sitting down and thinking, like not writing some paper with this intention, but it was just sitting back and thinking. And I think that is unfortunately a luxury. It's became a luxury for scientists and academics now just to have the time to think because you're so occupied with as a clinician scientist, you're seeing patients and stuff, which is part of your career. But on top of that, you have a million emails to respond to. You have to do all these other things you have. You have to also publish 20 papers now, or you to get this, academic position for or to maintain this for tenure and stuff like that. So we're so distracted that we're losing the science in front of us.
Mm,
You don't have the time to actually just do what you like or to think about because again, these people are so subspecialized. You're never going to get someone that knows so much. Like if you're in one of these subspecialized areas in a specific disorder in this, that's going to be the most knowledgeable person in that area. And you want them to just have time to think because they're going to be the ones that have the ideas. They know where all the gaps in their areas are. And if they have that, they can talk to someone else. But if you're having to respond to emails all day, do all this sort of thing, you just don't have time to think, which is interesting because that's why I take the time every single day. I at least read one paper just to think. I sit down, I have a list,
mm,
I have a whole document of just links. It's just it's a document of a Word document of links, and it's 63 pages long. So I'm never going to finish it. I read one paper a day, and as I find new things, even if it's something that I know nothing about, I will just read it. And that's why I do a
mm,
thread every day too. Sometimes I read more. Sometimes if I'm finished a call shift, I don't really want to do anything else. I'll just sit and I'll read like 10 papers. And just because I just want to like learn, I don't, it doesn't even have to be psychiatry. Like some of them are about the brain, some of them are about physics, some of them are about, and I don't have the credentials to read about some of these things to be fair, but I can still find it interesting and I can still try
yeah.
to understand. And I think that's where you learn the most. And I think the other thing too is, as you mentioned, like you go to these things where there's an expert in whatever disorder or whatever condition, and then you feel silly because you know nothing. But I think it should be like empowering, like never be afraid to be wrong. Like I'm wrong a lot too. People see your victories when you're winning your awards or where you have a paper that is highly cited or people are reading this thing, but they don't see how many times you're wrong. And I think that's where we get a misconstrued kind of view of figures in academia and everything. Most of these people that are in their high up positions and are all praised for everything, they were wrong a bunch of times. But
Mm,
they were not afraid to be wrong. They made all these things. People probably laughed at them for different theories that they had, and they were wrong. And maybe they weren't even wrong, but maybe just the culture in the moment was like that's ridiculous, and it became to be true. So I think that's the same thing you have to take into academia. Is it's okay to be wrong. It's okay for people to say that your theory is incorrect. Your paper is in. It's not okay to have errors and stuff in your paper that is. I mean, it happens, but it's not okay to continually do that. But it's okay to suggest something that ends up being incorrect, as long as it's not harmful to other people and that it
mm,
comes from a place that actually has some academic grounding. I think that's where we're so afraid now in academia is to be wrong because you're afraid to have a fool made of yourself. You're afraid to do all these different things, which leads off to this just closed off. And that fuels into what I said. That's why we become so hyper focused because you become hyper comfortable because you're this specialized researcher in this specific disorder. Nobody can correct you because you're the researcher in that area. And it's great, but then you lose the broad nature of what it could be to venture out from that specific interest. And I think that's the issue with academia. It's much bigger than that, but that's one of the issues in terms of academia and why we have these silos of knowledge.
mm. And then yeah, I mean, it just on that before I was going to put something quickly. Yeah, and I think that is it, like you said, that sort of publish or perish, and how academia is essentially defined by individuals who are contending with their own sort of pressures, and whilst they might always invariably be interested in academia and just science essentially, at the same time they have to understand, they have drives, motivations, they needs to put money, to get that better paid job, and to do that they need to get certain citations. But at what cost
Mm-hmm.
does that have to the macro in terms of the sort of the trajectory that science, or not necessarily science is too broad, but you know, a discipline is taking? Has it become, in the same way we were talking about psychopathologies being entrenched, you know, in these canalized states,
Mhm.
can that to an extent occur within a discipline of science? I'm not saying it ever does quite like that, because I think there's enough
Mhm.
sort of curiosity and the principles of good science sort of generally undermine that. But anyway, just on that though, I think
Mhm.
your work on X is sort of, yeah. How have you found? I don't call it work. I mean, I'm just
Mhm.
curious. How do you find it? You enjoying it? Is it?
Yeah, no, I
Yeah.
really like it. Like, if I'm being honest, I've been doing it for, I think, coming up on a year now. Like, I've had the account for longer, but posting threads and sharing stuff like from a public perspective, it's been about a year, and I've enjoyed it a lot. Like I said, it's been a source where I've read papers and stuff that I'm not familiar with. Like, at first, I started the same thing as you mentioned. I was just reading psychiatry papers. I was just posting stuff about like exercise and stuff because I didn't want to be like perceived as stupid in what I was sharing or not knowledgeable. But then I started getting comfortable and I was like, okay, well, I'll try to read other things. And that led me to reading different areas in psychiatry, then more of the neuroscience part. And then it kind of branched out from there to even sometimes just strictly physical health or just different things. And it's nice because I can read a paper. I'll summarize it, but I summarize it in a way that I hope, for the most part, most people can kind of understand. Like, I write it in this hybrid where both the general public will understand, but also that there are nuances that academics will appreciate. So putting effect sizes and stuff like that. I know that someone without the background won't understand, but I still describe what that effect size shows
Sure. Yeah. Yeah.
or to contextualize it, but I also want to add the effect size for the people that care about that metric. Because most people, I'm going to be honest, probably don't, but the academics do. So I'll put that in just for context of the discussion. But it forces me to read an article. It forces me to be able to describe it in a way that others can, which I don't know the exact quote, but from Albert Einstein, something along the lines of like, if you can't explain it simply, you simply don't understand it. So if you can't explain it, and what I try to do with all of my posts is it's usually a thread of different things. I could break it down, but I try to summarize the entire paper, and there are exceptions to this, in one line, like a very short sentence, with a descriptive picture, and then I go from there. And that's my effort to say, how can I shorten my understanding of this paper down into just one statement that other
Mm,
people will say, oh, this is kind of interesting. But it also forces me to say, what is the most important part of this paper? And trimming it down in just one sentence and then going there and describing it. And I think it's been good because I've, as I mentioned, reading papers. I also get kind of feedback from it too. So whether it's sharing my own paper or these other papers, it's kind of like peer review again, even if it's not my own paper. You get input because it's going out to thousands and thousands of people, and sometimes even millions of people see some of these threads. And you can imagine with that many eyes on it, you're going to get positive, you're going to get negative feedback, you're going to get critiques. And sometimes I'm like, hey, it's not even my paper. I'm just, I was just reading it. But I think it's interesting because I also learn from everyone too. The reason why I have this Excel sheet that or Word document that's 63 pages is I'm not just on Google Scholar or PubMed typing in words. I'm looking at what people send to me, and I'm like, oh, that's interesting, and then I'll bookmark it, and then I'll put it in my my endless document of papers because
great.
I see what people send to me, or sometimes people will have a question about a paper that I didn't even have that question, and then I'll look into that question, and then maybe I'll answer it indirectly in another thread, um, which I think is interesting. It's given me lots of research ideas for myself. It's led to a lot of connections. I'm actually doing like a keynote presentation, I think, next week for science communication for one of the journals as well too, which is nice to have that connection too. So it's both a learning experience. It's led to a lot of
Mm,
opportunities, and I quite enjoy it. Honestly, it's if I'm being honest, it's more enjoyable than just the just doing research because I think what I
yeah.
was missing when I was publishing a lot as a resident too. Like I don't even know the exact number, but per year we're talking about like one more than one paper per month sort of thing. So I was publishing a lot while in residency, which was getting to a point where it's kind of getting a little bit tiring. And I didn't to go back to the point of just thinking, I didn't have the time to just think. It was like, okay, done that paper. This is my next idea. Start that paper. And most of writing a paper isn't writing. Most of it is collecting the data, whether it's a meta-analysis, whether it's a cohort study, most of it's the data collection, stats, all that sort of thing. And then you get to write for a little bit. And that's usually the quickest for me because I write so much. I can write a paper up in one sitting. And I found that by doing the Twitter or X stuff, it kind of allowed me the time to think in an indirect way where I would find a paper every day, I read it, and then I summarize it, and then of course there's days I don't every single time if I'm like post call and I just didn't sleep all night, then maybe I'll miss a day. But I try to do it every single day to the best of my abilities. But yeah, no, I think it's been an overall great experience. Been, as I mentioned, for a year, and I plan on continuing to do it. And I think in the future, I hope to. I just don't have the time now. I hope to be able to expand to like video explanations of stuff as well too. I just, if I do that, I want to make sure that I have the time, the resources, and stuff to do it properly.
Mm,
Because I could do it now, but it just wouldn't be consistent. And I don't
yeah.
want to start something that I can't be consistent with. And I know some people would say, oh, just start it anyways. But for me, like I really enjoy the extra Twitter already right now. And I do see this expansion in the future. But as I mentioned, the biggest block is just I have an exam and like our big final
Yeah,
residency.
yeah, yeah,
And
yeah.
I
You
just
got a
want to be
big exam.
realistic. Yeah, yeah, and not overload myself. But
Yeah,
yeah,
and honestly, I genuinely I mean this as well. I think if you were to do that, I think you'd do great with it. I think, your enthusiasm, it's translated, it translates itself well through Twitter, but just talking with you, I
Hmm.
think, yeah, it would be
No, no,
something
thank you.
people would, yeah, definitely watch and appreciate for sure.
Hmm.
So yeah, well, it's been good talking.
No, likewise.
Um, so yeah, I mean, I guess we could leave it there. I don't want. I'm
Perfect. Yeah.
mindful. Yeah, I'm mindful. I don't. You got the rest of your day. Have your
No, no,
second
no.
coffee.
Yeah, I'm not even done the first. I just sip it. I'm slow. But
um.
yeah, no, thank you for having me. It was a pleasure to chat. And I'll check out the other episode that you mentioned about the philosopher
Yeah, it's
for
called
some
Peter
context
S.
too.
Yeah, Peter S. Hughes.
Hmm.
Um. Yeah. All right, Nicholas. Well, I'll continue to yeah, keep an eye out on your work and your Twitter as well. And yeah, all the best with the exams and everything.
No, thank you so much.
All right. Take care.
All right, take care.